There's various factors that can affect the heart rate, that regulate it. And so one thing that can do this is if the stroke volume, the SV, decreases because there's now less blood volume because of a weakened heart, less blood in the ventricle, that cardiac output is decreased unless it's compensated by the heart rate. Because remember, the formula for cardiac output is heart rate times stroke volume. So positive chronotropic agents and negative chronotropic agents are chemicals that can increase or decrease the heart rate. So let's look at the first factor that regulates the heart rate, called the autonomic nervous system, which you're familiar with. So for the sympathetic division of the autonomic nervous system, remember that's the fight or flight division. When there's emotional or physical stressors, there's a chemical called norepinephrine that's released into the bloodstream. And norepinephrine is a very powerful chemical that comes from the adrenal medulla. And it binds to specific receptors called beta 1 adrenergic receptors, and it causes the pacemaker, the SA node, to fire more rapidly to increase the heart rate. And as a result of this, the filling decreases, which should make sense because there's not enough time now for that ventricle to fill. There's decreased filling time. And there's increased contractility, so the ESV decreases because of increased volume of ejected blood. That ventricle now is pumping more forcefully. So the rest of the sympathetic division of the autonomic nervous system can change because both the EDV and the ESV decrease, which we just talked about in the last slide. So essentially, the stroke volume remains unchanged in this case. So it's kind of like a catch-22. So in that case, the heart rate has to compensate for that. So the heart rate is affected by the sympathetic division, the autonomic, and the parasympathetic division. So as you know, sympathetic is fight or flight, but parasympathetic division is the opposite of this. This is the rest and digest. And the main chemical, acetylcholine, is the neurotransmitter that is responsible for the parasympathetic nervous system. In fact, in medicine, when they give a cholinergic agent, that word has to do with causing a parasympathetic response. So when this happens, the heart exists, or the heart at rest is going to exhibit what's called the vagal tone. And the vagal tone is when the parasympathetic division is dominant. And this can decrease the rate quite a bit, as you can see, to 25 beats per minute. And that's going to be really, really bad. So in the case of athletes, we know that athletes have a low heart rate, so therefore they have a low vagal tone. However, it's not going to be this low of 25 beats per minute. So, in addition to the autonomic nervous system, there is going to be stretching of atrial walls, which are going to stimulate the SA node, increasing heart rate. But there's also other chemicals that can do this. So hormones are an example, and epinephrine is an example, which is very similar to norepinephrine, and they are actually both chemicals and hormones. So they call them neurochemicals, neurohormones, but they do the same thing. They increase heart rate and contractility. So remember that you need to know that heart rate and contractility go together. There's also thyroxine, which is the active version of the thyroid hormone. It's going to enhance the effect of these chemicals, norepinephrine and epinephrine, as well as ions, specifically calcium and potassium. Recall that calcium is really important for what's called the plateau phase of the myocyte, and then the potassium is for repolarization. So that could be dangerous to the heart. So our next slide shows a couple homeostatic imbalances. These are very easy to understand because of the root of the word. Calcemia means calcium. So if somebody has low calcium, hypocalcemia, they're going to have a depressed heart, a weaker heart. If they have too much calcium, they could have a higher heart rate or a higher contractility. Whereas hyperkalemia and hypokalemia, they have to do with potassium. And potassium alters electrical activity, and it can lead to a heart block or a cardiac arrest. So one drug that could be given to cause cardiac arrest would be potassium. And a low amount of potassium is not necessarily good either. It can lead to a weak heartbeat or arrhythmias. These are going to be misbalances in the ECG. The next slide is showing the two next homeostatic imbalances, which are tachycardia and bradycardia. I'm sure you've heard of these terms. Tachycardia is an abnormally fast heart rate, greater than 100 beats per minute, so very, very high. That's not normal. And bradycardia is a heart rate slower than 60 beats per minute. And remember that athletes may have bradycardia, and that's perfectly normal. So it's a desirable effect of endurance training. It's kind of like a sign that the muscle is well trained. So the next homeostatic imbalance for cardiac output is congestive heart failure. So in congestive heart failure, depending on what side of the heart is affected, it leads to problems. So the first one is if the left side of the heart fails. So remember, left side, think systemic circulation. If that fails, the blood is going to back up in the lungs because the pulmonary artery, remember, is bringing blood to the left atrium. So you have to kind of work your way backwards. The right side of the heart, if it fails, it's going to lead to peripheral congestion. And again, you're going to kind of work your way backwards. The right side of the heart is pulmonary circulation, and the blood that leads into the right atrium is from the entire periphery, from the entire body. Our last slide of this chapter is showing the developmental aspects of the heart. So there's a couple adaptations that are very important to know, and these adaptations are present in the fetal heart because the fetal heart does not have a functioning lung and liver at this point. So to compensate, there has to be several bypasses, and the two bypasses for the heart and the lungs are first a hole that's in the wall of the interatrial septum, and that closes at birth. And what causes that to close is an increase in pressure from the left atrium that causes closure of the foramen ovale. Because during fetal circulation, the blood in the two atria are mixing, but that has to close at birth. When they say a baby has a hole in their heart, we're going in to fix that, they're talking about an open, or what they call a patent, foramen ovale. So the fossa ovalis is the remnant that is seen in adulthood. Now the second adaptation for the lungs is a bypass between the pulmonary trunk and the aorta. So it connects the two. So at birth, we have something very similar that's going to happen here, but instead of just a hole closing, there's an entire ligament that is created. And that ligament is going to connect the aorta and the pulmonary trunk. Because again, during fetal circulation, that blood, that deoxygenated and oxygenated blood, is mixing.